Sorry, doctors, can you unmute yourself?
Well, good afternoon, ladies and gentlemen, and a warm welcome from Cape Town. I'm joined here this afternoon. My name is Peter de Jong, and I have with me Professor Stephen Jeffrey, who, as you all know, is one of the 10 best urogynecologists in Cape Town. So we have a wonderful film star this evening. Our speaker is Dr. Mpumi Zenda. She's an OBGYN sexologist and founder of We See You, a health and information consultancy. Her talk this evening is Female Sexual Functioning, What Women Want. It's a great pleasure to have her here on our platform. It's her first time. We haven't heard.
She's online, Pete. Doctor's in online.
She's not online yet. I'm just trying to check, what the problem is. She hasn't let us know that there's anything wrong. So maybe it's just a connection issue. If you can just give me a second.
Right. And while we're checking on the connection issue, I'd just like to warn you all and advise you all that we have SASOG coming up at the end of this month. And SASOG, as you all know, is in Sun City. And it's a great honor of all of us to troop up to Sun City and have a wonderful presentation over there. SASOG is presented this time by the University of Pretoria. And we have a whole lot of wonderful speakers. And I'm pleased to say the president of the Royal College of Obstetricians and Gynecologists, that's from London, will be over there with Abdul Sultan. Rani Thak, as you know, is an old friend of Cape Town, old friend of South Africa, and she, as the president of the Royal College, will be speaking, as will other wonderful speakers. The Royal College has sent a troupe of speakers over there to be with us at the end of this month. And as you know, there's also special offers. There are lots of special offers. And we have a special offer from our insurers, Steve Kellerman, and he insures NatMed, and they're giving special discounts also for people that wish to go up to the SASOG. So if you are a NatMed member and you wish to go to SASOG and you wish to enjoy the special discount, I'm sure it's something you should do. I've had a look at the program for SASOG, and it's a very wide and broad program. It contains wonderful speakers. A huge number of speakers are from overseas, so it's not only local speakers. I'm sorry you aren't able to go, but you'll be here holding the fort, Steve.
Absolutely. A pleasure.
Okay, thank you very much for that, Steve. I'm just going to ask Karain, as soon as you have our speaker on the line, Karain, Dr. Mpumi Zenda, the OBGYN sexologist speaker and founder of We See You, a health and information consultancy, we're going to let you know.
I will
Sorry.
let you know ASAP.
Okay. If we can't get it, Steve has a backup talk over here.
I'm actually just looking through some talks to see if I can, if someone still wants something on urogynecology. I mean, we do have quite a lot of people online, so we could certainly give something more urogyny related.
More urogyny than sex. Steve, coming up, we've got menopause and hormonal therapy. That's in the short distance. We've also got Imran Mia. He's having a talk on fecal incontinence. This is something, it's a very important subject. And as part of this talk, excuse me, Steve, as part of this talk, he's speaking on repair of anal sphincter incontinence and episiotomy and anal sphincter damage. Then, of course, we have Suleiman Halen. He's speaking about endometriosis surgery as it relates to the infertile patient. And finally, just before I sign off and give you over to Steve and the talk this afternoon, remember to make a note of FIGO, which is coming to Cape Town next year. FIGO is the CTICC, just next door here, and we have a magnificent lineup of 10,000 delegates and 1,000 people, and these people will be right next door, and I urge you all to make every effort to attend FIGO Cape Town. Steve, you have I see you have a speech over here.
Look, obviously we all a little bit surprised.
Cannot seem to get hold of Dr. Zenda or her assistant. So I'm so sorry.
Thanks so much.
Well, look, we don't have female section function by Dr. Zenda, but we do have something similar by Professor Jeffrey. And he is going to be doing a talk on
thanks. So we obviously let's seize the opportunity to talk about something else. It's absolutely fine, and I'm very happy to try and give a talk on something that I've given before. We've got a talk on hysteropexy, but I have found a talk that I gave quite a few years ago, but I think it would be quite useful to update everyone on local oestriol and urogenital symptoms, Pete.
Local oestriol and urogenital symptoms. It's a very important.
I think it's a very important topic, and let's just share these slides. And those who want to stay can stay, and those who want to pop off because of the change in topic are very welcome to do that. But I'll definitely be happy to take you through this, and we can look at these slides together, Pete. And I think local estrogen treatment is very important, and it's a completely underutilized treatment form. I do find a lot of patients coming with severe vaginal and vaginal atrophy not actually taking the estrogen. And so let's look at these slides together, and we can actually just see what we can get out of this one today. And I'll just share my slides, share my screen there. There we go. And there we go. And so this is a talk I gave quite a while ago in Prague. And so excuse my somewhat lack of preparation for this. That's Saint Catherine.
Saint Catherine of Prague.
Patron saint of incontinence.
A patron saint of incontinence.
Yeah.
That's not a very flattering moniker to have, Steve.
But it's very important.
Of course.
That's St. Vitus, patron saint of
dancing.
Constipation.
Constipation.
Believe it or not. So so
you're expanding our knowledge here.
So urogenital symptoms are quite extensive, and the types of things that actually get manifested by this urogenital syndrome of menopause, which is now the new name for what was previously called vaginal atrophy. And you get the external genital symptoms, the urological symptoms, as well as the sexual symptoms.
So the new moniker is genitourinary syndrome of the menopause.
Absolutely. So
GSM.
and then you can actually see the range of symptoms that patients actually have. And it goes all the way down from pain to dryness, irritation, discharge. I think the important one, if you want to look at this, you can actually see the pH over here. And as the vulva becomes atrophic, the pH starts to rise to become more alkaline. And that is very important in simple thing like a problem of recurrent UTIs. And so that's why we really need to get on top of this in patients who do have things like recurrent UTIs. And then moving all the way up to the meatal stenosis. I saw a patient once when I was a registrar who presented with incontinence. And when I examined her, she'd actually got a fusion of the labia minora to the point of where she was collecting urine inside the vagina and within the vulva in this fused labia. And she had a small trickle of urine coming in that little hole that was at the one side of the fused labia. So very important to get on top of this. And obviously from a sexual point of view, it is very important. So this is the sort of range of symptoms that we might find. Okay, so local estrogen therapy is very important. And there's some good data actually to show that it doesn't only work on the actual histological improvement of the number of cells or the quality of the cells, but it works even to the level of the nerves. And this is an histological and a nerve-related study where you can actually see that when they it reduces the number of sensory nociceptor and autonomic motor nerves in postmenopausal vagina. So as you improve the estrogen receptor content, you get a reduction in the pain receptors of the vulva. So there's even a level of a sort of micro neurological level as you treat these patients with hormone therapy.
Steve, just go. It says topical hormonal therapy. Does it matter what topical hormonal therapy, or is that important? Must this be as a pill, or must this be as a cream, or must this be as a pessary, or does it really not matter what topical hormonal therapy?
The local estrogen therapies are the most important. You don't want to be giving an oral one. You want to be giving it locally. Topically. It has to go locally. Topically.
But which of those topical?
We're going to look at that.
Oh, we're going to look at
slides as they unfold.
Okay.
And we can look at that. I think there's something about that later in this talk that I looked at about 5 years ago.
Okay, let's have a look.
Okay, so, but there you can actually see, and this is not something that either me or Peter are actually familiar with, but this is an immunofluorescence photomicrograph. But in essence, this is really just showing that you get an increase. You get a reduction in the sensory innervation of the vagina, and in fact, really just reducing that sensitivity of the vulva and vagina by the administration of the local estrogen therapy. So let's just get down to the next slide, So let's just get to the next one, I think. So when it comes down to incontinence, we did some research at Urogenital in collaboration with some people from Amsterdam and also in Australia. And we gave these patients Oestriol, Synapause, and we found a significant reduction in the amount of incontinence in those patients. So in this case, it was actually using Synapause.
So is that available still?
Synapause is available in South Africa. It's an excellent option in those patients, and I think it certainly is something that.
So Synapause is something that you should keep in your armamentarium, ladies and gentlemen, because it is. I know at one stage it wasn't available. So if it's once again available, it's nice.
So the question is why would it, So why would it improve your incontinence? Why would giving just a simple thing like a local estrogen cream improve your continence? And so firstly, it improves your urethral blood flow. It increases your alpha-adrenal receptor sensitivity.
Urethral blood flow.
Yeah, because it's obviously stimulating improvement in your vascular supply to the urethra. It increases your urethral closure pressure, and it obviously improves the cellular maturation in the bladder, trigone, and the urethra. So that's why it would potentially improve your continence.
So does it matter what sort of continence? Is the stress incontinence?
Well, Pete, in fact, it works on both. But in our study, we looked specifically at the stress incontinence patients.
Right. So So after a woman presents with stress incontinence, you give a topical steroid, topical estrogen cream, and they get better. And
Yeah.
you use Sinopause in
Yeah.
the study. Okay.
Now, if you know your big studies on systemic HRT, and I mean these studies have been quoted, I would have to say ad nauseum. Whenever you hear a talk on menopause, you're hearing about the Women's Health Study, Women's Health Initiative study, the HER study, the Nurses Health Study. If you remember the data on stress incontinence, these actually showed that they worsened, which was very counterintuitive. And I do remember when I was a registrar, all those years ago, sitting with old Tama Tindi, who you'll remember very clearly. And when someone presented this data on stress incontinence worsening on women's health issue, he was very surprised. And I remember him making one of his very funny comments to me about this. So it's interesting that it actually, so the oral HRTs actually in this study showed that it worsened incontinence.
Steve, yeah, I remember that, Steve. But what worries me is when they drew up the WHI,
yeah,
why were they looking at stress incontinence? Isn't this just something that came up as a secondary finding? Because how can, if you are studying menopause and a very large epidemiological study, was this sufficiently powered? Was this one of the endpoints, the effect of hormones on stress incontinence? Or was it just something that they found as an epidemiological aside?
look, I don't think it was one of the, I don't know specifically one of the outcome measures. I don't know the detail of these studies, but it certainly sounds like it was a significant deterioration from a statistical point of view. So, I mean, I think it is something that one needs to think about taking seriously. And I think the bottom line is that you need to tell your patients that if she does have incontinence, her symptoms aren't going to improve on the oral hormone therapies. You do need to target it with a local therapy.
But having said that, Steve, in the real life, what they call lived realities, and I've got many dozens, if not hundreds of women on hormonal therapy. I've yet to have one complain, and they do complain. This one says I've got bigger breasts. This one says I've got fluid retention. This one says I'm gaining weight. Not one has ever said they got worse stress incontinence. Okay. And that is what I call a lived reality.
Yeah. So, yeah, I mean, there are some theories around why the oral hormone therapies might not work as well. And they say they've been shown to have a total reduction in total collagen content. Cross-linking in collagen is an important factor, which people talk about all the time. And there was also there's also potentially increase in the level of collagen turnover markers. But again, I think from a practical point of view, absolutely, Pete, I don't think we see patients complaining about a worsening in incontinence. And yeah, I mean, it's just really not going to improve it, and you do need to target it with a local therapy.
Right, got it.
Local administration of the estrogen has a different effect. It's more easy able to target the periurethral tissues, improve the mucosal seal. We certainly know that the local estrogen therapy on vaginal ectomy is undisputed. So there must be some sort of physiological reason why the local therapy is working better, and there's very good data now to prove that it does work so well. Okay. I think we're going to run through this to the next one. Types of local estrogen therapy.
That's the question.
That's the thing that I think we really need to talk about.
Steve, are these things called local estrogen therapies or topical estrogen therapies? What, or does it not matter? Yeah, I suppose with lots of nowadays estrogen therapies that are applied cutaneously, would those be topical and vaginal application would be local? Is that right?
Yeah, so I think this is a very important thing you bring up, Pete. So remember, we've got Femigel, which is it's a gel it's a systemic hormone therapy, and that is administered through the thin part of the skin, and that is different to the topical. So I don't know what term to use, but I would maybe say systemic and local estrogen therapy. That's maybe the term I would use, but I don't know if there's a term that has been accepted by the Menopause Society.
I'd say topical vaginal or local vaginal. That means you're actually saying this, you can call it local to the vagina or topical in the vagina, but I like the term vaginal because then there can be no question as to is this topical on the skin or local to the skin. If you do say vaginal, then we know exactly where it's going.
But it can get confusing, especially for patients. You're already getting, say, Femigel, and then you say, well, you need to take some Premarin cream. I mean, you know, they need to understand the difference. And that's where obviously the confusion will come in.
Yeah.
Okay, so you got the creams. We all know Premarin, one of the sort of real stalwarts and still widely used. And then you've got your Sinopause, which is Oestriol. Okay, so there is a difference between the two. You've got this is conjugated equine estrogen, which has its origins in pregnant mares, and that's where they get the term from, pregnant mare urine. And then you got Oestriol, which is a synthetically produced Oestriol. Remember, Oestriol is a more physiological hormone than the conjugated equine estrogen. So that's maybe why some people would prefer it. And
So,
that's
sorry to interrupt.
yes.
Now, what is more natural? I mean, if it comes from pregnant mares' urine, let's get over the fact that it's horse urine. That sounds inherently more natural than something that is, what do you say,
Oestriol
is made out of?
Well, it's a synthetically produced hormone, but Pete, we have estriol in our system. I mean, the estriol is a naturally occurring hormone. So you're basically replacing something that is already there.
Okay, so
but no one has conjugated equine estrogen in the system. So you are
unless you're
adding something that is not physiologically part of a human's, you know, a woman's physiology.
Yeah. Okay.
And then you've got Vagifem. Okay. Now Vagifem is different because it's estradiol, number one. But the other thing is that it's actually also a tablet. So it comes in that little applicator. You push the little button at the back, it releases that tablet into the vagina. And so it is a lot more attractive for many reasons. Number one, it's just a little bit easier because it's less messy. And that little applicator is a once-off use. So you throw it away after each use, whereas the Premarin comes with an applicator that gets used every day, while the you know, the tube is still got some stuff inside it. So that's why some patients actually prefer it. But I do find the Premarin to be better if you want a cream. And often you'll see a patient who's got quite severe external atrophy, and that's why I'd maybe want to give the Premarin rather than the
so you can give the Premarin cream externally to the labia, perhaps, or to the labia minora.
I mean, very occasionally I'll actually give a patient on both. A little bit of Vagifem into the vagina and some on the external.
Oh, really? Okay.
Okay. We had the S-string, the ring. It was called the I think it's called the S-string. It was a ring that women kept into the vaginas, and it released estradiol, but it was pulled off the market. I don't know why, and I didn't really have any experience that it was pulled off the market before I really started practicing. So, did you use it, Pete?
Well, we've got the Nuva rings, Steve. Now, the Nuva ring is a contraceptive ring.
Yeah.
That's obviously a combined contraceptive. It's about the same size as that cartoon you've got there, and it's inserted for 3 weeks of the month. And some people think it's wonderful because of it's absorbed topically vaginally, and they like it. So although the Nuva ring is both, I can understand that if you like the Nuva ring, you would like that form of vehicle to deliver your estrogen.
Yeah. All right. So so estriol is the one, and this really was a talk focused a little bit more on the research that we did on the Sinopause. And it was really very much estriol. And for that reason, I focused this talk on why estriol. And again, we can just summarize the indications for patients who would need this estriol. And we know that it works in atrophy, overactive bladder, recurrent UTIs.
How does it work? Yeah. How does it work in recurrent UTIs?
Well, again, Pete, I've said to you that it improves the pH. A low pH is better for recurrent UTIs. You want a more acidic pH, and the good quality vaginal cells produce more glycogen, which then gets converted to glycolic acid, which then makes the pH more acidic, leading to a better vulval environment to prevent UTIs.
Got it.
I do like using it in patients with pelvic organ prolapse simply because if you improve the sensitivity of the vulva, vagina, and the actual prolapse that might be pressing or rubbing on underwear, etc., you might improve the symptoms of pelvic organ prolapse. Although I don't think it will reverse the prolapse as such, it does actually help a lot. And you might take a patient who might be ready for an operation by giving them some aggressive vulval therapy with estrogen. You might improve their symptoms quite nicely. So I do like to use it in every patient with pelvic organ prolapse. Everyone with a pessary needs to have regular and ongoing Premarin cream. And that is something that I find is a problem because I see a lot of patients who are managing pessaries. They'll come and tell you they're having some bleeding and they've actually just forgotten, or maybe I might have not emphasized enough the importance of taking the Premarin. So when you see them, and I do advise seeing patients with pessaries at least every 6 months, make sure that they are taking that on a sort of at least twice a week basis.
All right, because we've got lots of women here
Yeah,
on pessaries.
yeah,
So it's important.
yeah.
So it's important that those women at least twice a week get their topical vaginal
absolutely,
estrogen.
yeah. And then again, I do find Premarin to be a very useful for my post-op patients as well. Premarin, Sinopause, it's remarkably good at wound healing, and you know, even within a week I will often give a patient the Premarin to improve their symptoms. So you get that patient who's maybe not healing well, maybe you've done a posterior repair or a perineopathy or even a post-op postpartum patient, you might want to give some. And in fact, that's one indication I didn't put on here, but you get a lot of patients who breastfeeding. Remember, breastfeeding is a hypoestrogenic state, and you would want to give some of those patients some Premarin cream to improve their vulval atrophy, their vulval symptoms, and it does actually work quite well. But do remember to take out the package insert.
Why?
Because it says they're not for use in patients breastfeeding.
Yeah, but
And
that's like a disclaimer.
yeah,
I mean, if you look at any package insert that covers medication to be given to pregnant women, all of them without exception have a disclaimer not for use. And if you look at vitamins, they're pretending that they're not even medical indicated. So it's important to stress that whatever you're doing to pregnant women, they must understand it's in a sense off-label, but probably absolutely safe.
Yeah. Good. So those would be the indications. Yeah. So this physiology is maybe a little bit rusty from our side, so maybe I would not want to embark too much on this. But one of the advantages of Oestriol is that it has a slightly different effect on the cellular level. So number one, it doesn't have as much of a endometrial effect if it does get absorbed as the estradiol. So remember, estradiol is your vagifem, whereas your your estriol is your sinopause. So that is the one advantage possibly of it.
So Steve, did you say which one has less effect? I know the vagifem, that's the pill, has very little effect indeed on endometrial proliferation. What does the estriol have on effect
Well, this study basically showed, and it supported the fact that it doesn't have any adverse effect on the endometrium, and so basically really showing that it is possibly safer to use than maybe estradiol, which has a higher chance of binding to the estrogen, the endometrial nucleus.
Well, that begs the question: are these things safe in breast cancer?
Well, that's what we will be getting onto.
Okay.
Because I just wanted to run through. There was I'll get to that, Pete, actually.
Okay,
because there is actually a study a little bit later on where the binding of the estriol to the nucleus in the breast is only for 6 hours, whereas with estradiol it was much longer, more than 24 hours. So there is definitely a physiological advantage to estriol over your estradiol. So I think if you are going to be giving any of these treatments to a patient with a history of breast cancer, you probably go for an estriol rather than your estradiol.
Wasn't the dosage, the actual milligram dosage, reduced in VAGFM?
It was, but I don't remember why that was done, Pete. But it is now. I think it's 10 milligrams now, where it was 25 milligrams before.
Yeah,
Yeah. So, all right. So, just a little bit of data on estriol and on the urogenital rehabilitation, and here you can actually see looking at various symptoms like your stress incontinence, vaginal dryness, dyspareunia, atrophy, and bacteria. Remarkable improvements in these, and very significant improvements in patients taking that. So there you can actually see very good data to support the use of estriol. Looking at your maturation index, which is a sort of an objective measurement of atrophy, significant improvements after only 21 days of 1 milligram of estriol. So I'm just going to come back to this. Now, this was another study from Zulo, menopause in 2005. And again, yeah, you can actually see that in this very small randomized trial of TVT or TVT plus estriol after 6 months, there was some advantage in urgency in patients which you added some estrogen. So it seems to be a very good option in patients who have had a TVT, but with some possible mixed symptoms, some urgency on the side. So I think it's something that we really need to be I believe being quite liberal in treating patients with. And this is again from another study, but it's again small numbers. Here we go. You can actually see why it might work so well in your patients who have your recurrent UTIs. Again, leukocyturia, bacteria, and everything really seems to be so much better in patients. But I think the real point to this slide is looking at the pH. Significant reduction in the pH of the vagina, and I think that is the real crux behind really improving the symptoms in these patients with recurrent urinary tract infections. Okay, here's the Cochrane review. I think we're just going to run very quickly through that. So this was just again, Peter, really speaking off the cuff here, and this was some data. This was a study that we did at UCT, and it's quite old now, published in 2016 in
8 years ago, not that old.
Yeah, in fact, and you don't even have the new data. We actually ended up publishing 3-month data after this as well. But we used Ovestin. Ovestin is the European name for Sonopause. We actually got ethics approval for this, and as soon as we got ethics approval, they took it off the market in South Africa for a few years.
Oh, no.
So we had to find somewhere, and we managed to get it, and we carried on doing the research on it. But basically, and yeah, I want to give credit to my student Judith Suchet, who came from Netherlands and was here for about 3 months doing the study, and Kate Moore in Sydney, and then you'll know Jan-Paul Rufus, who was also part of the study. So it was 53 patients, 3 centers, and they had 6 weeks of treatment, and there you can actually see the treatment protocol: 1 milligram a day for 3 weeks, and then 1 milligram 3 times a week for 3 weeks. And so it was 6 weeks treatment. And we looked at a number of different parameters. Yeah, we used the PGI, which is the Patient Global Impression Improvement. We were looking specifically at stress urinary incontinence. Okay, and that was one of our most important outcome markers. And the important thing to remember here was that firstly, on the PGI, we had significant improvements. I think this was actually also very interesting. So these are all very good questionnaires that are used extensively in urogynecology research. This is the IIQ. But importantly, in the study of 53 patients, there were significant improvements in the irritative symptoms and stress incontinence.
Both.
So, yeah, so we were very, very surprised actually to see how good the estriol worked after only 6 weeks in patients with stress incontinence, and this was objectively measured. It was a really nice study where we you know, I believe we really recruited the patients properly in all 3 centers, and we followed up very nicely with these pre and post questionnaires. So you can actually see very significant improvements.
Do you just go back? What did you say was your dose? Did you say every night?
1 milligram. So it was, just go back to this, 1 milligram a day for 3 weeks, and then 1 milligram 3 times a week.
Okay, so for 3 weeks every evening, and then a milligram for 3 times a week for 3 weeks.
Yeah.
Now, is that the usual dose? Because you know that
But it's too high. Yeah, I mean,
that VAGFM is 10 micrograms, which is it 100 or 1,000?
The standard, your Premarin is 0.5 grams, Pete. So 0.5. This is the double the dose in this study. This is something that we did discuss at length, but it didn't seem to have any adverse effects on these patients.
Do they have side effects? There's no systemic effects from, for example, increase in weight, fluid retention, breast increase, none of that.
We do see, I certainly see those side effects in my patients. Actually.
Yeah.
I'm sorry this hasn't been updated. Would have obviously prepared a lot better if I knew I was actually going to be giving this talk. But we did actually then take this to a 3-month follow-up. So we extended the study, and in fact the symptoms were the patient took the treatment 3 times a week for an additional 6 weeks. So they had 1 milligram daily for 3 weeks, and then 1 milligram 3 times a week for 9 weeks. And in fact, with the patients continued to improve and were even better. So you can actually see how many patients on the PGI experienced an even greater improvement. So after 12 weeks, 3 months, we had an even better improvement. IIQ, very significant improvements in stress incontinence. So the stress incontinence on physical activity, travel, emotional health, and all those outcomes was remarkably improved. But I think the outcome that surprised me the most actually was the pads. So we actually did pad tests on these patients, and they got a pad, pre-weighed pads, pre and post. So it was objectively measured with a patient with a weighed pad, and my students unfortunately weigh these pads, and but there you can actually see significant improvements in the pad tests in the patients at Oestriol. So it really seems to have made a significant difference here, and so that was something that did surprise me, and I think it is something you can offer to your patients who don't want to go for some sort of surgical intervention. The dose has been discussed at length, and you can see the different studies using different doses of your Oestriol. Okay, so yeah, that's really just that little bit of data. We at that stage were discussed embarking on a further study with multi-center study looking at a lot more extensive parameters and looking potentially even at using it in patients with breast cancer. We unfortunately that multi-center trial never actually happened, although it went quite far. And yeah, so the bottom line about local Oestriol in urogenital symptoms, it's safe. We believe it's highly effective.
So it's safe, but can you use it in breast cancer sufferers or not?
We do.
You do.
We do. And
okay.
the gynae,
all of you, any one of them. I mean, not only VAGFM.
Pete, it's a complex group. And I would not embark on treating anyone with vaginal or estrogen hormone therapy without getting a guide from the patient's oncologist. Because remember, there are all sorts of nuances here. They have estrogen receptor positives. Some of them are already on receptor blockers, etc. So, but absolutely, these patients are often desperate for help. The patient we've gone through the whole gambit of breast cancer treatment, coming out on the other side having survived, but her sex life hasn't survived. And they want to get on with their normal lives. And this is one of the biggest issues. And this is something that is unfortunately profoundly ignored by the treating team, which I mean, is partially understandable, but yeah. Highly effective improvements in UTIs, very few adverse events, and encouraging data on urgency. This data on stress incontinence seems to be quite good, although I'm not aware of any further research on this, and I haven't looked recently. And but there is a large scope for future research onto this. And just as one final aside, on these patients with breast cancer, remember I've given a talk previously about the role of laser in this group in patients with atrophy, and it is actually, in my opinion, quite a good alternative. So if you've got a patient with breast cancer who doesn't want to go on hormone therapy, refer them to someone for laser as well.
Yeah,
so that's an option there.
Steve, I've just got a
Yeah.
I've just got a question over here from Anonymous, who's Habib from Nairobi. He says, when would you use topical estrogen therapy? When would you use lasers? Because he was here at that talk you gave on the use of laser therapy in menopausal atrophy. When do you use what? Or do you start with one? What is your algorithm? Yeah, that's the word. And when do you use what?
Look, Bill, I think the bottom line is that hormone therapy is a lot more available. It's, you can give it by prescription, and the data comparing the two shows that they are actually quite comparable in the outcomes.
The data between hormonal and laser.
And I mean, I'm happy to give the laser my laser talk again, but the data has increased profoundly in the last 12 to 13 years in which laser has been available, and the results of the laser for atrophy versus hormone therapies are actually quite comparable. So you're probably getting almost the same effect from the laser as you are from your hormone therapies. So look, I mean, I don't offer an atrophy patient laser from the beginning. I will always first try the hormone therapy. We know that hormone therapy is tried and tested.
And
yeah, laser is not covered by medical aid. The costs are anything between 3,500 to 7,000. I was actually having a conversation with one of my colleagues this morning about that. I charge 3,500 Rand per treatment.
Per treatment, and how many treatment courses would you need?
I normally give three. 1 month apart. But yeah, it does work. And I will always start with a hormone therapy. I think that is a standard treatment. I think if you've jumped straight into laser on someone in whom there isn't a contraindication to hormone therapy, you might be doing something that is out of sort of standard practice. And so I prefer not to pop straight onto the laser. I don't think I even discuss laser with patients without first trying at least on some hormone therapy. I think it's sustainable. Hormone therapy that can stay on for life. Laser does drop off after about 6 months, and then do need to come for another treatment. So you want something that is sustainable, that don't need to keep coming back for.
Steve, just to pick up on this sexologist thing, we've heard about incontinence. We've heard that these topical estrogens improve continence in many global ways. What is the effect on sexual function?
The topical treatments.
Yeah.
Well, Peter,
is it proven?
Yeah, absolutely.
Or is this a placebo effect?
Yeah, I mean, I didn't show you the data, but I mean, absolutely. I mean, improving your atrophy, improving the lining, it certainly improves that. I'm not aware of any data in someone who hasn't got atrophic effects. I don't think it would improve that. I'm not sure.
So it's not a catch-all. You can't say, if a woman says, I'm having poor intimate function postmenopausally, you can't say, yeah, try some Vagifem.
I can't really give you a proper answer on that, but okay. I don't do that in my own practice. I mean, do you do that?
You'd first obviously have to see if they do have any atrophy, but I personally start with things like vaginal lubricants. We had that wonderful talk by the sexologist locally, Dr. Rudolph, and she said you should use lubricants that are not water-based, that are based on silicon-based.
Absolutely, yeah.
So that's where you start.
The problem with those things is that you can't just walk into Dis-Chem or Clicks and buy those things.
You can.
Can you?
Yeah.
Okay. Which one do you recommend?
Astroglide.
Astroglide.
No, not Astroglide.
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 Oh, okay, yeah.
As in spear, Astroglide.
Okay.
Spear of the nation.
Is that a silicone-based? Okay.
That's silicon-based. It's not.
And what about Replens? Is that also?
Is that a hyaluronidase one?
No, I think it's also silicone-based. but absolutely,
Replens.
yeah, there's something called Replens.
I better just Google
Okay,
that and
all
see.
right. But
I do
Assagai's the
know.
one.
I
So
do know
Assagai's
that-
the one to go for, eh?
Assagai is the one. Here's
Okay.
the one, and it's not water based. It's actually silicon based,
Okay, well,
and that's why Dr. Rudolph said it's the best one to use.
okay, good. All right, well, sorry for the change in plan, but I'm sure we can get.
Are there any
Our,
questions there?
There's nothing that's come out on the chat, and I think hopefully we can reschedule with Dr. Zenda. I don't know if she's appeared, but yeah. And
Good heavens.
were you looking up something else there, Pete?
I was looking up Replens on the Google, and it's marketed as a product here called Wet Dreams Vaginal Lubrication Supplement. So look, a lot of these things, Steve, you buy at the corner store, and they look a bit suspicious to me. But having said that, just stick with what we said, Assagai, and there's many products available, and I would say some of them look a bit dodgy.
Okay.
So just stick with the Assagai.
Assagai.
Yeah.
Okay. All right.
Assagai, and thank you very much indeed, Steve, for
Pleasure.
stepping into the breach at the last moment. We do have a talk next week, Menopause and Hormonal Therapy by Percy Moodley. He is the, in fact, Menopausal Association person in South Africa chairman. So it's going to be wonderful hearing him present. And to all those of you that have logged on this evening, I wish you safe home. Thank you, Steve. And we look forward, same time, same place next week.
Thanks so much, Pete. And yeah, we'll see you all soon again. Thanks so much.